3, 2, 1, go, sir.
Hi, good evening. Uh, extend a warm welcome to all the participants today on this Saturday evening for an exciting session with our some of our key note speakers. The discussion would be on the topic called pancreatic exocrine insufficiency in diabetic population and uncharted terrains. I mean, it's quite an exciting topic when we discussed with a few of our clinicians that this is one of the it's not so common, but at the same time, that is one of the concern that the today's clinicians have to look forward to when they are treating the patients with diabetes. And we thought that we should have a kind of discussion with some of the clinicians who are dealing with diabetes and the gastroenterologists dealing with pancreatic enzymes, and also the physicians with expertise in terms of managing the patients with diabetes with this kind of problem. And we were successful in pulling in some of the best minds in our country today for this evening webinar. And they're going to share a lot of information and details about how we are going to deal about this particular condition in today's in today's our day-to-day patient and today's our day-to-day practice. Just to go ahead about our meeting webinar today, since this gives us an opportunity to interact with many of the physicians all across India, I would like to give a brief introduction about what Hetero is all about. Hetero, as you're all aware, is a leading pharmaceutical company, I must say. And I must also tell that we are very young when it comes to some of the existing pharmaceutical companies in India. We started way back in 1993, so it is just 28 years since we have been in operation. But I must say that in this 28 years, Hetero has achieved a far more bigger name as compared to many of the players that have been in this segment for quite some time. We are not only present in India, we are present in more than 60, 70 countries across the world with our operations and field force directly promoting and executing the marketing operations of the organization. I must say we started off as basically as a API manufacturer, that is active pharmaceutical ingredients. And slowly we went ahead and developed formulations which have been many to name. But at the same time, I would say that we are one of the few pharmaceutical companies in India which is vertically integrated. So we have a lot of expertise and experience in terms of ensuring that the entire supply chain has been managed and the products can be made available without much difficulties and without much lag. One of the biggest strengths that Hetero has today. We have more than 20 manufacturing state-of-the-art manufacturing facilities. These facilities have been approved by some of the regulated markets like US FDA, UK MHRA, and South African CC, just to name a few. And I must also highlight one important aspect about Hetero, which is the biologics plant. I think very few companies in India have the expertise of developing biological products. And we ventured into this particular segment and ensured that we bring in some of the best biosimilars in India. I mean, we started with something like rituximab, went on to bring products like adalimumab and trastuzumab. And recently, we have also developed tocilizumab, I think, which has been widely used in today's COVID management as well. We had issues and challenges when it comes to tocilizumab availability in India. But I think with our product being developed, and we have made some supplies to the government as well in the recent past. So with that, I think we'll be able to manage some of the issues that the challenges that are there. I think this is one area, I must say, the DNA of the organization, that we did not really look at the business and the commercial aspects of the products, but looking at the need of the hour and the requirements, we ensured that the products are being developed and made available in India. I think our response to COVID treatment, that is the excellent thing that one can quote about. More than 2 million patients in India alone have availed our remdesivir molecule. Even today, God forbid, we should not expect a third wave, but we are ready to produce anything between 5 to 10 lakh remdesivir injections within a short span of 7 days. So that is the kind of backup that we have made ourselves, so that to face any eventuality that might come up. Apart from the COVID, I must say that we have also made a significant presence in HIV/AIDS, rheumatology, oncology, and nevertheless gastroenterology. I mean, not many of you must be aware, but it was the first company to introduce pantoprazole and rabiprazole in India. Though I mean, the brands were not made so big at that point of time, but that clearly shows the strength that Hetero has when it comes to bringing the products and formulations. That credit goes to our R&D team, I must say. We have a dedicated Hetero Research Foundation, HRF, that what we call. There are more than 500 scientists working round the clock in terms of developing this all these molecules. So whenever we develop a molecule, it's not just for India, but it is for the rest of the world as well. So we don't have two quality policy. So what is being manufactured for India, that is the same product is being exported in other countries as well. So we ensure that the same quality is passed on to the patients in India as well. So that is just to give a brief about the organization. I think it's a wonderful opportunity that today we could connect with all the physicians that are participating in this webinar, and we have wonderful speakers, and I'm sure that the speakers are going to ensure a scientific treat for all the participants on this wonderful topic like pancreatic exocrine insufficiency in diabetes, which is uncharted terrains. So with this brief introduction, I would like to introduce our moderator of today's session. Can I have the slide, please? So our moderator is Dr. Manas Barua. Just to give a brief introduction about Dr. Barua, he is the promoter director, head of the Department of Endocrinology, Excel Care Hospitals, Guwahati. He is the editor-in-chief of JMNN, associate editor of IJEM and TRP. To his credit, he's been a reviewer of various journals, member research committee, RSS, DI, and ESI, and he has published more than 152 articles in peer-reviewed journals. He has authored 17 book chapters and presented 37 international abstracts. There are 25 consensus and clinical guidelines with 4826 citations, which he has presented in his career so far. And just to mention a few awards that he has been conferred with: IJEM Best Original Paper Awards in 2011, Economic Times Inspiring Endocrinologist Award in 2021, and Great Minds of 21st Century by ABI, that is American Biographical Society, recently. He's been a part of various clinical trials such as Improve, Leader, Dual IV, Arise, Soul, Canamet, and Achieve. With this, I would like to welcome our moderator, Manas Barua, and I request him to take forward today's proceedings.
Thank you, Mr. Nehru. Thanks for your introduction, kind introduction, and thank you very much for taking us through the journey you have traversed. Quite exciting and quite commendable. And thank you very much for the contribution you have made to the people of India in this juncture, because I remember using a lot of remdesivir last year from your company, and you were the one who helped us a lot. We had contacted you directly, I guess. My team contacted you directly. Thank you anyway. And today we are here. It's a exciting panel with a speaker whom I know for a long time. And the topic is Pancreatic Exocrine insufficiency, uncharted terrains, especially for people like me. It's quite uncharted terrain. Like we always deal with the endocrine part, that is beta cells and alpha cells of islet cells, but we actually leave aside the exocrine dysfunctions to our gastroenterology colleagues. But I think there is something we need to learn now, because the problem is there. And to discuss that, we have got our experts from the field of internal medicine, from the gastroenterology, and from the field which I belong to, let's endocrinology. But before that, I would like to introduce our speaker today, Dr. Rupjuchi Talukdar from the Asian Institute of Gastroenterology. May I have his introductory slide? Of course, I don't need a slide because Rupjyoti and myself, we belong to the same medical school. We belong to the northeastern part of India, but more particularly from Guwahati. I've known him from almost 30 years, more than 30 years now. So he is now the director of pancreatology, Asian Institute of Gastroenterology, a pioneer institute, which is known nationally as well as internationally. It's head Pancreas Research Group and Division of Gut Microbiome Research, Institute of Basic and Translational Research, Asian, in his institute in Hyderabad, and fellow of Indian College of Physicians, Asian Gastroenterology Association. He had done a postdoctoral in USA, Mayo Clinic to be precise, and he has also been an associate editor for Digestive Diseases and Sciences and the BMC Gastroenterology, an editorial board member of Pancreatology and Indian Journal of Gastroenterology. He has been a peer reviewer for 27 international and 2 national journals and American Gastroenterology Association in pancreas section. Quite an honor, quite an achievement. He published more than 100 scientific articles, very quality articles, well cited, and over 40 abstracts, 18 book chapters, and 13 conference proceedings. He has delivered numerous invited lectures in both international, national, as well as in regional conferences. He has won many awards, to name a few: American Gastroenterology Association Fellowship 2021, Fellowship of Indian College of Physicians 2018, Welcome DVT Fellowship in 21 and way back in 2017, and various others. So with these achievements, definitely we are going to be benefited by his experience and his knowledge, which is going to deliver through his lecture today on pancreatic exocrine insufficiency. And before I end this introductory slide, I would also mention that he is a great musician because he's a good keyboard player, if I remember well from his school days. So over to you, Rupjyoti. I can call you first name.
Yeah, sure.
Yeah.
That is an honor. Okay, so can I share my slides? Okay. Okay, so is the slide visible? I think, yeah. Okay, so let me start. So very good evening, ladies and gentlemen.
Sir,
So,
the slide is not yet visible.
Yeah, it's visible now?
Yeah, now.
Yes, yeah.
So many of you must be wondering, what is this exocrine guy, a gastroenterologist or a pancreatologist, doing in a endocrine gathering, physicians, endocrinologists. So that is what, first I'll have to justify why I am here. And after that, I'll take you through the uncharted terrains in this area of pancreatic exocrine insufficiency and diabetes. So what I'm going to do is, just to justify why I am here, I have to take you back to 500 million years of evolution. So if I had been there 500 million years back, probably I would have given this talk, because at that time, if we look in the early living creatures, in the lower strata of the living creatures, the islets, pancreatic exocrine and the endocrine systems were very separate. The islets were scattered throughout the gastrointestinal tract, and there were, and the as Brockman bodies, and the exocrine structures were separate in another location. But as evolution happened, and as we became humans, from fish, from apes to humans, a very complicated network of exocrine and endocrine system developed. And the reason is because there has to be lots of interaction between these two separate organs. Even though these two organs are dealt with by totally two different specialities, in reality, there are lots and lots of interaction going on, which is helping us to maintain our metabolism and the normal physiological function of the body. And therefore, I think I'll divide my talk into two parts. The first part would be more on the endocrine exocrine crosstalk. And I think this would be very important to understand what happens when the exocrine failure happens in the patients with diabetes, which will be relevant to most of the audience today. And in the first part, I'll basically talk on the impact of the islet hormones on the Axiner function, and also the impact of the Axiner system or Axiner enzymes on the islet function, and to see what interaction happens between these two closely knit systems. And then that would be followed by the clinical aspect, which will be of interest to everyone, I guess. And I think from this part, we can also discuss later on about how to go about in working in this area in India, because very scant studies are there from India. And I think we really need more basic science studies, more clinical trials, and more clinical studies. So to understand this, how these two organs, the endocrine and the exocrine component of the pancreas, are linked. So if we see here, if we remember our histology classes, first year MBBS, if we remember the glomeruli in the kidney, it looks like this, but these are glomeruli from the pancreatic islets. So even the islets have a very tightly knit capillary system called the glomeruli. And this is an electron microscopic cast image. So what happens whatever blood comes into the pancreatic islets, they will wash the whole islets, and then blood will go from within to outwards of the islets. And when it goes outside from the islets, it will wash all the Axiner cells around the islets. So this is one islet, and these are the peri-islet Axiner cells. Similarly, another islet will lead to the blood flow, and that will wash the islets, the Axiner cell around them. So even though only 1% of the pancreas is composed of the islets, the blood that flows through the islets will wash the whole 99% of the acini. So that is the beauty of this system, and that is why this interaction is so important. And what is the result of this? If we see, this is an islet, and these are the peri-islet acini. And this was a beautiful study done many years back in the 60s, I guess. And what this is called the halo effect. This is an electron micrographic picture. And if you see, this black color indicates the pancreatic enzymes within the Axiner cells. So this is the islet. And if you see here around the islet, the Axiner cells are more dark and size is bigger compared to the cells far away, which means that these cells are having more zymogen granules, more pancreatic enzymes, and they are larger in size. So why does it happen? Why is it like this? So again, several studies all these years have shown that there are insulin receptors. So this is again an Axiner cell, and this is the basolateral surface of the Axiner cell containing insulin receptors. So the insulin and all the other islet hormones that goes out from the islets just wash or get exposed to the islets or Axiner cells around the islet, and that lead to an insulin, as we know, has a trophic action. It has a growth promoting action. So because of the trophic action of insulin, those islets around the those Axiner cells around the islets are bigger and they contain more enzymes. So this clearly shows that there is a close interaction between the insulin, endocrine pancreas, and the Axiner cell. Then further studies have actually also shown the presence of the GLP-1 receptors in Axiner cells. So we'd expect GLP-1 receptors in the endocrine cells, which is known. This is the islet, and all these dark dots are GLP receptors. But in the same pancreas, we also see these are the Axiner clusters, and the same black dots are also seen in the Axiner cluster, which indicates that the GLP-1 receptors are also present in the Axiner cell. So why it should be present there? This indicates that there could be some interaction. When the GLP hormones would come to the pancreas, it will impact both the Axiner GLP receptors and the islet GLP receptors. And of course, these are studies done in animals because it's very difficult to do this kind of studies in humans. So when the animals, mice were treated with GLP-1 or exendin and liraglutide for 7 days, what the authors observed was there was an increase in proliferation of the Axiner cell line, isolated acini, and even the intact acini within the mouse pancreas. And there was also an associated increase in the pancreatic enzyme secretion. So this clearly shows that this GLP receptor signaling can also lead to Axiner cell growth and Axiner secretion. And if you remember, there has been lots of debate when these GLP analogs came into the market that it can cause pancreatitis, and there were lots of FDA warnings and lots of concern. But what later on came out through the LEADER trial, many of you are aware of this trial, and many other studies from cardiovascular literature, this GLP analogs actually do not cause pancreatitis, and it just increases the lipase and amylase. And this is the mechanism. It has a trophic action on the acinar cell, and it produces more acinar enzyme into the blood. So this is again a very good example of exocrine endocrine interaction. And then even more recently, there were studies done on pig models. And again, these are difficult studies to be conducted in humans, but pig models are very good in a sense that they mimic the human physiology, especially the digestive and pancreatic physiology, very closely. And I'll not go into the details of these experiments, but again, pancreatic digestive enzymes, especially amylase, was found to reduce postprandial hyperglycemia. So amylase is usually meant for digestion of starch, but here in this experiment, it was clearly shown that it can also reduce a postprandial hyperglycemia, and it was insulin independent. So it has an independent mechanism, again proving further that there is a strong exocrine endocrine interaction in the physiological functions of the body. And the most hot topic currently, and a very recent paper that has shown is that pancreatic and exocrine function can also be associated with the change in the intestinal microbiome, or the microbiota composition and diversity. So this was a very good paper that was published 2 years back in Gastroenterology, where almost 1,800 volunteers were selected from a population-based study, and presence of pancreatic exocrine insufficiency was tested by the fecal elastase test. And what they found was there was an alteration in the enterotype. So these are, again, I'm not going into the details of what enterotypes are, but these are clusters or groups of microorganisms. So these are the enterotypes in healthy controls who did not have pancreatic exocrine insufficiency. And this is the group of individuals who had pancreatic exocrine insufficiency. And there was a reversal in the ratio of the enterotype 1 and enterotype 2, indicating that there is gut microbial dysbiosis, which was associated with the pancreatic exocrine function. And in fact, the authors could observe significant changes in the abundance of 30 species or 30 genus. And there was an increase in Prevotella and decrease in Bacteroides, which indicated a shift from the type 1 to type 1 to type 2 enterotype. And there was lots of significant changes in the organism, and there was associated with alteration in the pancreatic fluid secretion. So this again is an interaction between the exocrine and endocrine pancreas, which is mediated possibly by the gut microbiota. So now it's becoming more and more clear that even the gut microbiota is important in mediating this crosstalk between the exocrine and endocrine pancreas. So to summarize this part, how the exocrine function affects the endocrine function and vice versa. So this is what we call the Enteropancreatic Axis. And if we see here, this is simple to understand. The pancreas would secrete amylase, lipase, and proteases, which is a known function, and it would cause digestion of the important components like starch, fat, and proteins. And now this is known that amino acids, glucose, and fatty acids could activate the K cell, which leads to the release of GIP in the duodenum. And then they also leads to activation of the L cell in the distant small intestine and colon. That will lead to production and synthesis and secretion of the incretins. So I will not go into the details of all this receptor-mediated mechanism. And where does gut microbiome come into play in this whole scheme? If we see here, whenever we take diet, the undigested fibers of the diet are acted upon by the intestinal microbiota. And as a result of which several short-chain fatty acids are produced, and of which the most important in a healthy situation is butyrate. And the short-chain fatty acids are also shown to activate the incretin producing cells in the small intestine and colon. And finally, what they do is they produce the incretin, and which contributes to the euglycemic state. So if the diet of the patient is not good, or if the patient do not have good fibers, if they have bad fibers, or if the patient has alteration in the gut microbiota, then the butyrate production comes down, and other harmful short-chain fatty acids like acetate gets overexpressed. So in that case, that could contribute to reduction in incretins, and that may contribute to dysglycemia. So this is how the pancreatic exocrine function, the microbiome, and the incretin system interact in maintaining the euglycemic status in the human body. So now let's come back to something very close to all of us here, putting the whole concept that I just discussed into a clinical perspective. So this is a real life story of a 56-year-old male who had been suffering from type 2 diabetes for 7 years, and he was initially taking oral hypoglycemic agents, but was now converted to insulin. He had a fairly good glycemic control, but then he started developing diarrhea and weight loss. His primary physician somewhere else had rightly checked for the routine examination of stool, which was normal. Hydrogen breath test was normal, and he was also complaining of some bloating and weight loss. And I think again that was a good idea to do a CT scan to see if there was anything harboring inside, but CT did not show gross abnormality. There was slight slight reduction in the size of the pancreas, but which was not which did not appear to be clinically very significant. But because of the diarrhea, he received multiple courses of antibiotics like rifaximin, norfloxacin, ofloxacin, sorry, and he was also given antidiarrheals. And then finally, he was referred to AIG with a diagnosis of type 2 DM, which was fairly controlled well, with the query, is it IBS-D or something else? So at AIG, we took a thorough history, and he gave a very clear history, like it was a semi-solid, voluminous, foul-smelling stool, which was very typical of steatorrhea, of presence of fat in the stool. And we did a fecal elastase, which was very low, 40. And based on that, we started him on pancreatic endocrine replacement therapy. And within 3 months, so this was the outcome. His bowel movements improved, diarrhea improved, there was significant weight gain. And what was most interesting was there was improvement in the glycemic status. So there was reduction in the insulin requirement. So this clearly shows that this disease is not uncommon in the real life clinical practice. And many times they are evaluated for different causes of diarrhea. They are given antibiotics, they are given antidiarrheals, several things. But usually at many levels, the possibility of exocrine insufficiency is missed or not thought of. So the next subsequent discussion will deal with this aspect. So if we talk about, so this means that the patient had exocrine insufficiency. And so if we look at the epidemiology, there has been many studies since 1943. And earlier studies were done by the direct test. I'll come to that a little bit later. And the prevalence of this entity called pancreatic exocrine insufficiency in these type 1 and type 2 diabetes was shown to have a wide range, 27 to 80%. And then later on, several indirect tests came up, and out of that, the most common is the fecal elastase. And when fecal elastase was used with a cutoff of less than 100 microgram per gram of stool, which is defined as severe pancreatic exocrine insufficiency, the prevalence of PEI was found to be around 53% in type 1 diabetes patients and 50% in type 2 diabetes patients, significantly high and worrisome number. And in a later study in 2006, where the authors did a systematic review, they evaluated 17 studies with nearly 4,000 patients. And here they used the fecal elastase of less than 200. So if we talk about fecal elastase, less than 200 is supposed to be diagnostic of presence of insufficiency, and less than 100 is supposed to be a definition of severe pancreatic exocrine insufficiency. So in this study, again, the authors had showed in type 1 diabetes, there was almost 40% prevalence of pancreatic exocrine insufficiency, and in type 2 diabetes, it was around 28% or 30%. So these are all Western studies. What about India? So do we have exocrine insufficiency in Indian patients? So this was a study published 5 years back from Dr. Prasanna Kumar in Bangalore. Again, they had tested fecal elastase to diagnose exocrine insufficiency. There were 89 type 1 diabetes patients, 95 type 2 diabetes patients, and very important in this kind of study to have healthy controls, and a very good number of healthy controls, around 90. So what they observed was 30% of patients with type 1 diabetes, and again 30% of type 2 diabetes patients had exocrine insufficiency, which was similar to the data shown by the recent systematic review. And there was a significant correlation between the HbA1c and the pancreatic exocrine insufficiency, the value of the fecal elastase. So this is a real situation even present in India. And therefore, I'm sure all of you have encountered these patients, and many of you, I'm sure, have treated these patients, but this is a real problem. So let us see what happens. Why does it happen in these diabetic patients? So if we take the example of type 1 diabetes, again, I don't have to talk about the mechanism of type 1 diabetes in this group of audience. So it's basically autoimmune destruction of the islets, and there will be insulitis beta cell injury, and with time there will be loss of beta cell, and finally the patient will culminate into florid clinical diabetes. So this is autoimmunity, and because of the autoimmunity, because of the islet damage, there will be reduction of insulin secretion. And as I've already said, if there is less insulin, the halo effect won't happen. The trophic action on the exocrine pancreas on the islets will go, and the islets will start producing less enzyme. So from that perspective, pancreatic exocrine insufficiency in diabetes happens much early, at a very young age, because this is a disease that begins at young age. So exocrine insufficiency also happens at much young age. But recent data, recent research have shown even something more interesting. Up to 70% of patients with type 1 diabetes also has autoantibodies against exocrine antigen, against the bile acid dependent lipase and many other exocrine antigen. So the damage or the reduction in exocrine secretion in this condition, type 1 diabetes, is not only because of a lack of the trophic action of insulin, but also of active apoptosis or active damage to the Axiner cells itself because of the autoantibodies. And if we look at type 2 diabetes, again, type 2 diabetes would present a bit later. There will be a long pre-diabetic stage, and over time, the patients should develop again the microvascular, cardiovascular complications. And at a later stage, there will be more of glucotoxicity and there will be less insulin. So initially, it's more, the insulinotrophic effect keeps on happening in the Axiner cells, but eventually at a later part of the disease, there will be insulin deficiency. But then we do see many patients with type 2 diabetes having pancreatic exocrine insufficiency even in the early stage of the disease. Why is it so? So again, now several research work have shown that there is increase in immune cell infiltration in the exocrine pancreas in patients with type 2 diabetes mellitus. So this immune cell infiltration can cause active injury or active secretory defect to the exocrine pancreas, and that's what probably explains why many of these patients may have exocrine insufficiency even in the earlier stage of the disease. So now talking about the microbiome, I had just talked about microbiome and how it interacts with the normal incretin function and the digestive function. So in this paper we had published recently, we looked at the gut microbiome in type 1, type 2, and type 3C diabetes. So if you see here, this green indicates control individual, which have a totally different microbial profile. Type 3C diabetes or pancreatogenic diabetes in patients with chronic pancreatitis have a totally different profile. And these two areas indicate the profile of type 1 and type 2 diabetes. And when we looked at the individual species, there were 39 unique species to type 2 diabetes, 35 unique species in type 1 diabetes. So, and there were 63 specific unique species in type 3C diabetes. Only 31 species were common in all the three types of diabetes. So this shows that there is significant difference in the gut microbiota in type 1 and type 2 diabetes. And this difference in the numbers and unique organisms probably is because of the different mechanism of these two diabetes. Type 2 diabetes begins as insulin resistance, and it follows a different pathway, while type 1 diabetes has more of insulin deficiency and immune mediated beta cell damage. So that could probably explain why we see a different profile. And when we looked at the individual species, there was significant reduction in something called Ruminococcus bromai and Vibrio fibris solvens. And both of these are supposed to be the good guy, the good bacteria, which is responsible for production of The good short-chain fatty acids predominantly butyrate and also mediate the mechanism. So these are probably contributing to incretin action, incretin-mimetic effect, and that's how it could contribute to the glycemic status. So when these are reduced, again, the incretin function probably diminishes. So we need more mechanistic studies to answer the question, but these gives us clear direction in which this mechanism is moving. And then again, this may not be relevant to type 1 and type 2 diabetes, but just to confirm further that the gut microbiota has definitely an implication in diabetes. So this is another paper that we published in 2017, where we looked at the microbiota in patients with chronic pancreatitis and without diabetes and with diabetes. Again, here, if we see there is a significant difference in the gut microbial profile in patients who had chronic pancreatitis with diabetes and without diabetes. And when we looked at the individual species, there is something called Faecalibacterium prosnitziae, again, which is supposed to be a good bacteria in terms of maintaining the gut mucosal barrier, producing lots of short-chain fatty acid, that was significantly reduced. It was progressively reducing in patients with diabetes, and it was even more significantly reduced in patients who had diabetes compared to the healthy controls. So this again shows the importance of microbial dysbiosis. And then we went one step ahead in this study, and probably this could also work in type 1 and type 2 diabetes. We need to prove that. So what we looked at was these organisms had had significant functional abnormality, where lots of LPS pathways were upregulated. LPS means endotoxin, and the same patients had a parallel increase in the plasma endotoxin level, which implies that the endotoxins or LPS that was produced by the gut microbiota has translocated into the blood through a leaky gut, and loss of Faecalibacterium prosnitziae caused alteration of the gut barrier, and that was significantly correlated with the glycemic status. And it is known that endotoxins can cause beta cell apoptosis or beta cell death by NF-kappa mediated mechanism. So this proves that gut microbial dysbiosis, at least in chronic pancreatitis, is directly responsible or directly associated with beta cell dysfunction and diabetes. So probably this could also have implications in type 1 and type 2 diabetes. So what pathological changes happens in these patients? So this was again a very elegant study from the Mayo Clinic. So again, systematic review of 50 studies. And what the authors observed was there was significant change in the pancreatic morphology. If you see here, this is an example of chronic healthy control chronic pancreatitis. So there is lots of acinar fibrosis. The islets are intact, but there are lots of acinar fibrosis. Similar fibrosis is also seen in type 1 and type 2 diabetes. Sorry, the 2 is missing here. So all these are fibrotic band between the acinar clusters, which means that even in type 1 and type 2 diabetes, there is acinar or pancreatic fibrosis. So this was more so in type 1 diabetes. Up to 50% of type 1 diabetes had pancreas reduction in the pancreas weight, volume, and size. That was kind of variable in type 2 diabetes. Lots of fibrosis was there, but inflammation was very minimal compared to chronic pancreatitis, where there is more inflammation. And the pancreatic duct was not altered in type 1 and type 2 diabetes, but there was lots of hyalinization of the arterioles. And both the function of the pancreas, as we have already discussed, was low, as recorded by the fecal elastase 1. And going one step ahead, there was also changes in the electron microscopy. I'm not trying to scare you by showing this complicated picture, but just to get into the perspective of how this damage happens. So this is again a normal pancreas. So this is the acinar cell, this is the islet cell. So there is a very close contact between these two. But when we see a chronic pancreatitis, diabetes patients with exocrine insufficiency, if you see here, the gap between the exocrine acinar cell and endocrine acinar cell has increased. There is fibrosis, and then there is also alteration in the gap junction proteins or the zona adherens or the desmosome. So this shows that the problem is not just at the physiological or at the clinical level. It goes deep into the ultrastructure of the pancreatic morphology or the histology. So, which indicates that this is more of a permanent kind of change. When there is fibrosis or this gap junction increases, it's highly unlikely that it will go back to its normal state. So to summarize the whole mechanism of how this happens in these patients, I had already talked about microangiopathy, macroangiopathy. Then microangiopathy will lead to neuropathy. So to summarize, it's a function of time. As the disease progresses, the insulin deficiency would increase. Even in type 2 diabetes, at a later stage, insulin deficiency will set in, and that leads to the loss of trophic action. Microangiopathy would lead to tissue ischemia. Neuropathy would lead to loss of the neurohormonal signal. So the signal that leads to exocrine secretion would be lost or impaired, and there will be inflammation both in type 1 and type 2 diabetes, as I had discussed. And the net loss or net effect of this is the loss of exocrine function. So now again, coming back to the clinic. So how to diagnose this patient? So this is a diagnostic dilemma. Many physicians would think of exocrine insufficiency in this kind of patient who had long-standing diabetes, diarrhea, weight loss. But the problem is there are no guidelines in the context of type 1 and type 2 diabetes. There are some guidelines in chronic pancreatitis. I think the British guideline just touches upon the exocrine insufficiency in diabetes, but there are no detailed guidelines. So it becomes very difficult for the physician to decide whom to test. Will it be rational to test everyone? Would it be, so whom do I test? So these are common diagnostic dilemma that is frequently encountered in the clinic. So to understand which patients of diabetes, which diabetic patients are at a higher risk of developing exocrine insufficiency, so several studies have proposed few risk factors, and of those, the important ones are insulin deficiency, poor glycemic control. Again, this is understandable. Elderly patients, which means they will have a longer duration of diabetes, and with age, there is natural degradation of the exocrine function. The duration of disease, some studies says it is a risk factor. Some studies are skeptical about it. Of course, if the patient has microangiopathy, autonomic neuropathy, these are the patients who are at a high risk. So how to prove it? How do we prove that the patient does have exocrine insufficiency? So one thing could be clinical assessment. Weight loss is a common feature of exocrine insufficiency. Diarrhea may be there. There could be dyspepsia and bloating because of the steatorrhea in India, at least in chronic pancreatitis, we've seen only 18 to 20%. But the problem is these are all non-specific markers. So diabetic patients could have SIBO. Type 1 diabetes could have concomitant celiac disease. Because of the diabetic status, they could have enteric infection. IBSD is common. And many of these patients are on metformin, acarbose, which are known to cause diarrhea. So this, just by presence of this, does not necessarily tell us that the patient has exocrine insufficiency. So again, biochemical assessment, micronutrient deficiencies can happen pre-albumin transfer, and they could be surrogate markers. They are not direct markers. Fat-soluble vitamin deficiency, I think more than half of India has vitamin D deficiency. A, K, and E are not done routinely. So just by doing vitamin D deficiency does not necessarily indicate that they might be having exocrine insufficiency. Vitamin B12 could be a surrogate marker. Not too many studies have addressed this entity, because if you see the physiology for vitamin B absorption, there is R factor which binds to the intrinsic factor binds to the vitamin B, and it has to be cleaved before it can be absorbed into the terminal ileum, and that cleavage happens because of the pancreatic colipase. So if there is exocrine insufficiency, there will be less colipase, so B12 would not be cleaved and there will be deficiency. So that can be a surrogate marker, and we do see many patients with pancreatic exocrine insufficiency have low levels of vitamin D in chronic pancreatitis. And maybe someone can take this up as a thesis study, actually, which could be an interesting thing to see. Now, how to confirm these were all surrogate markers, and at many levels they were non-specific. So can we do something that would actually tell us about the real pancreatic secretion? So for that, we can do pancreatic function test. So pancreatic function test, if you remember one of my earlier slides, I was talking about direct test and indirect test. So in direct test, what is measured is whatever secretion happens in the pancreas and comes to the duodenum. That is what are the direct tests, and we can see the secretion of secretin and CCK. But these tests are not routinely available only in very few select centers, and is done under research protocol, because these are complicated. We have to do it endoscopically or put some tubes inside. So direct tests are not done, so it is out. What about the indirect test? Indirect test is what we see the function of the pancreatic enzyme. We do not measure the exact amount of enzyme, but we see the function of the enzyme. So two such tests are available. One is the fecal fat quantification. So we actually see how much fat has been secreted in the stool, and if it is more than 15 gram, so that indicates steatorrhea or pancreatic exocrine insufficiency. But again, one have to collect 72 hours of fecal fat and send it to the lab, and so this is very messy, and no technician would love to do that. So this is also not done routinely. This is done only under select research protocol. There is another good test which is as good as the fecal fat, or maybe better. It's the triglyceride, carbon 13 level triglyceride breath test. So the patient is asked to take a radioactive carbon containing meal, and if there is if the pancreatic lipase is functioning well, then this will be cleaved from the and released into the breath. So if the measurement is more than 58%, then the patient is not having exocrine insufficiency. Again, this is not available widely, available only in 1 or 2 centers in Spain. So the only test that is left with us now is the indirect test called fecal elastase. So fecal elastase is an enzyme that is secreted in the duodenum. It is very stable. Whatever is secreted in the duodenum reaches the stool. It is not degraded during its transit through the intestine. So this is supposed to be one of the currently available tests in India. But again, this test has a little problem. So this can, the sensitivity for both mild and severe disease widely varies from 33 to 100%. Again, specificity is very wide. Even though it is stable, if the patient has watery diarrhea, watery stool, it may be falsely negative. So one has to be very careful while ordering fecal elastase test, and while interpreting the result, one has to be extremely careful so that they are not dealing with a false positive result. So since there are no guidelines, we have to go with some pragmatic, practical guidelines or approaches. So what I would do in my practice is, if a patient with diabetes have frank steatorrhea with or without gross pancreatic atrophy, on imaging, we can actually start with a PERT, because steatorrhea is the telltale evidence of exocrine insufficiency. Here we need not do any kind of test, be it surrogate markers, be it exocrine, and be it the fecal elastase. The second situation is if the patient has non-specific symptoms. He has diabetes, but he has weight loss, flatulence, and nutrient deficiency. But again, these are non-specific, can be because of various other reasons like SIBO. And so if they meet the risk criteria for PEI, long-standing diabetes, insulin deficiency, high dose of insulin requirement, in those we can do a fecal elastase test, and if it is low, we can start off with a pancreatic enzyme replacement. And in the third situation, the patient can have non-specific symptom. At the same time, he has diarrhea. Diarrhea can be again because of drugs, because of SIBO, because of celiac disease, and he meets the risk criteria for PEI. So in that, the first step would be to rule out the other possibilities of diarrhea like SIBO, celiac disease, autonomic neuropathy, take a good history of the drugs. And if they are ruled out, then fecal elastase test can be done, and then that would give a true positive fecal elastase test. So therefore, the crux of this is the index of suspicion should be very high. Since there are no guidelines to fall back upon, a very high level of suspicion is mandatory in the diagnosis of exocrine insufficiency in the patients with type 1 and type 2 diabetes. In chronic pancreatitis is kind of easier because the pancreas is already having a loss of parenchymal tissue. There will be atrophy, ductal dilatation, obstruction. So that makes the diagnosis easier. But in type 1 and type 2 diabetes, it would be very important to have a strong index of suspicion, and then following this pragmatic guidelines, I'd call this practical or pragmatic approaches, would help the physician to diagnose PEI. So now once we have diagnosed PEI, we need to treat them, and the treatment is pancreatic exocrine replacement therapy. So what does the evidence show? So there is only one paper published more than 10 years back, which evaluated PERT in patients with insulin-treated diabetes mellitus. So they call it insulin-treated. So probably they are a combination of type 1 and insulin-requiring type 2 diabetes. And PEI was detected by low fecal elastase. This was a prospective multi-center trial. 39 patients were randomized to pancreatin, 41 to placebo, 16-week duration of study. So they could not actually see any difference in the HbA1c and some of the clinical parameters, but they did not measure objectively the nutritional parameters. The goal of pancreatic endocrine replacement therapy is improvement in the nutrition. And these clinical features may be non-specific, not related to PEI. So probably that was a flaw in the study because the authors did not objectively measure the nutritional parameters. But the good thing was it was safe in these patients. But the other good thing they observed was there was a reduction in mild and moderate hypoglycemia. So this was, to my knowledge, the only study that has directly dealt with patients with diabetes. And then there were a few other studies on the use of exocrine in this enzyme supplementation in patients with cystic fibrosis. I'm not going to discuss the effect of enzyme in chronic pancreatitis. That's a separate story altogether. But if we see here in these two patients, the exocrine insufficiency, the exocrine and pancreatic enzyme replacement therapy had slowed the gastric emptying and normalized GLP. This is important to understand because we have already talked about how GLP can interact with the exocrine function and of course the endocrine function. So if there is a normalization of the GLP, there could be improvement in the exocrine function as well as the diabetic status. And in the second study, again, there was a tendency for improvement in the gastric emptying and GLP-1 secretion. And there was excellent correlation between the gastric emptying and glucose concentration. So again, these are studies that were done that were pretty old and the sample size was small. So I think it is time where we should think about more randomized controlled trials. And I think India, nothing can be better than India because of the number of diabetic patients with all the complications, PEI, diabetic related complication. So I think the lack of this knowledge actually warrants a good multi-center randomized control trial to see the effect of pancreatic enzyme replacement both in the endocrine and the exocrine function in these patients. So I think we can discuss this later on and come up with some trial design. So when actually this CME was conceived, I just talked to these people from Hetero to just do a survey and see how practitioners, how physicians, endocrinologists, diabetologists look into this problem and how many of them or how they treat these patients. So I would not say that this is a very good survey and I'm not very sure about the participants, but overall the raw results, if we see, almost 1/5 of the physicians were not aware of PERT and many of them would use them sometimes or very less. So there was a variable use of the PERT. So how should the treatment be initiated in these patients? So this is not only about the science of pancreatic exocrine replacement, because there are many layers which goes beyond guidelines and real life practice. So I always love to call this as the science and art of PERT. So this is what I call the golden rules of PERT. So it's most important is the right timing of administration of the enzymes, the right preparation and the right dose. So what is the right timing? So the enzyme preparation has to go and its function is in the duodenum. So it has to go with to the duodenum along with the food chyme that passes the pylorus. So it has to be given along with food or just before food. But in the Indian context, what we have observed from our practice at chronic pancreatitis, if we tell the patient to take this just before or just after food, that do not remain just before. They would take the enzyme preparation, go and do some other work, or take just after, take the meal, and instead of taking immediately after, they'll do some other work and then take. So the easiest and most effective way in the Indian context would be to take along with meal. They will take half of the meal, and then they will pop in a pancreatic enzyme capsule, and then they would complete the rest of the meal. So this is what I meant by along with food. So duodenal delivery with food kind is the rationale. Then the right preparation, again, there are different preparations in the market. So the most important thing is the pancreatic enzyme works in the duodenum. So, and pancreatic enzymes are like proteins. So the gastric acid would degrade those proteins here. So it has to be enteric coated. And then other important thing in the preparation is it has to pass through the chyme, through the pyloric channel with the food chyme. And this is only 2 millimeter. The pyloric, the chyme size is 2 millimeter, and that 2 millimeter chyme goes through the pyloric channel. So the pancreatic enzyme has to be microspheres or 2 millimeter or less. And there are even lesser, like less than 1.2 millimeter, they are called mini microsphere. But the studies have shown that mini microsphere and microsphere doesn't have any difference, but it has to be a microsphere less than 2 millimeters. So this is the enteric coated mini microsphere is the right kind of preparation. And finally, the right dosage. How do we determine the dose? So if we again go back to the physiology of the pancreas, the most important enzyme preparation that is required in this enzyme preparation is lipase. For amylase and proteases, there are backup enzymes, but lipase do not have a backup enzyme. And lipase is very vulnerable. Even in a normal person, only 1% of the lipase that is secreted in the duodenum reaches the stool. So the most important component in exocrine replacement therapy is lipase. So if we go back to the physiology, the daily lipase output is 6 lakh unit, and we need only 10% of this for minimal fat digestion. So that brings the dosage to minimal dosage to 60,000 unit, and it can be divided into 20,000 into 3 times daily with the major meals. But now in the market, there are 25,000 and 40,000 preparation. So if the patient has severe exocrine insufficiency, it's a good idea to begin with a higher dose, 40,000. When digestion improves, patient feels better, it can be tapered down to 25,000 and maintained at 25,000. Now, there is an issue of compliance in these patients because these enzymes are expensive, so it has to be prescribed with a sense of responsibility. It should not be prescribed when they are not needed, and therefore it's important to make a right diagnosis. And it's very important to explain to the patient why they are being given these enzymes. It's not for glycemic control, it's not for pain control, it's for their digestive improvement in the digestive system. Because we have seen these patients are non-compliant, one because of cost, and the other because of they think that it is not working. So if the patient do not know why they are taking this, there is a high chance that they will be non-compliant. So that patient counseling for taking these medications are important. Sometimes there can be cost constraints. So if the patient is having a low size meal or patient is having a breakfast which do not contain lots of fat or lots of calories, they just take things like cereals or oats. So in those situations, a 20 or 25,000 unit is not necessary. They can take a lower dose for breakfast. If they're taking a heavy lunch, they can increase it during lunch, and likewise. Suppose the patient wants to go for a party and they have a wholesome meal. On that day, they can take 25,000 or 40,000 in. So these enzyme doses are not very fixed because they do not have a pharmacokinetic action, pharmacokinetics like antibiotics or analgesics. They work with the amount of meal. So the dose can be titrated based on the amount of or the volume of the meal they are taking. So the right dosage, again, I just mentioned these things. If the patient want to have a bigger meal, he can increase the dose. If he want to have a lesser meal, he can reduce. If the patient is obese, he would require a higher amount of pancreatic enzyme compared to a lean patient. If the nutritional patient status of the patient is poor, he will require a higher dose. So these are very dynamic things that can be decided by the physician. But for an optimal function, the minimum dose required is 25,000 units. So that should be the baseline. But the other thing is, again, this is a paper from chronic pancreatitis. Many of these patients, I just said, feels that they are not being benefited by this pancreatic enzyme. And maybe the same would hold true in patients with type 1 and type 2 diabetes. So what we looked at was, in these patients, I think I have 2 or 3 more slides, maybe it's already 8. So what we looked at these patients were, we divided the patients into 3 groups. So the group 1 had been taking pancreatic enzymes religiously, like 25,000 units thrice daily with each meal for at least 3 months. Group 2 patients were irregular. Some of them had stopped, some of them skips a dose. And group 3 did not take any pancreatic enzyme for 3 months. And what we saw was their nutritional status was similar. Even patients who were taking pancreatic enzymes religiously had the same proportion of nutrition, malnutrition compared to the patients who were not having at all. So why was this? So when we tried to look at the function, the mechanism or the cause, what turned out was patients who were malnourished, be it in any group, whether they were taking enzymes or not taking enzymes, they were taking low calories. So low calorie intake was significantly responsible for persistence of malnutrition even after enzyme therapy. So why these patients were not taking food? Because many times patients with chronic pancreatitis, steatorrhea, and even in type 1, type 2 diabetes with steatorrhea are advised to take fat-free diet, which is wrong. Because if the patient is taking enzyme, the substrate of any enzyme, this is again basic biochemistry, requires a substrate. For action of enzyme requires a substrate, and for the lipase, which is the most important enzyme, requires fat for digestion. So if the patient is not taking fat in the diet, this enzyme won't work, whatever dose they take. And again, in chronic pancreatitis, this is again data from chronic pancreatitis, fear of pain, and decrease in appetite, anxiety, depression. So all these contribute to their eating less and persistence of malnutrition. So the point here is, if a patient of PEI who is on PERT should be asked to take a normal balanced diet, they should not be fat restricted. And it's very important to give them thorough dietary counseling and also counseling on why these medications are given to them. So, and it's not only about giving PERT, these patients are also having lots of inflammation and lots of other micronutrient deficiencies. So these micronutrients do not require pancreatic enzyme for digestion. So this should be replaced in these patients because these are frequently deficient. So along with the pancreatic enzyme supplementation, they should also be given micronutrient supplementation. And there are several causes of inadequate response, and in the context of clinical practice, underdosing and non-compliance can be dealt with by proper counseling. But many of these patients with diabetes and in general are given antacids, high fiber diets. So antacids and high fiber diet can reduce the action of the pancreatic enzyme. They will bind to the pancreatic enzyme and they do not act. So a patient who is been prescribed PERT, antacids and high fiber diet should be avoided. And how to assess the response, I think this is the last slide. Again, unfortunately, we do not have any specific objective test to assess the response in India. The triglyceride breath test can assess the response, but again, I already said it's not available in India. So what is left with us is the clinical parameter. If the patient's weight is improving, his bloating is gone, he's feeling better, there is improvement in the nutritional status. So these are surrogate markers. I can't call these as objective markers, but these are surrogate markers, which can tell us that the pancreatic exocrine insufficiency is improving. And if there are any postgraduates in the audience, so this is the future of PERT. So there are several new PERT technology that have been developed, not yet come to the market, but hopefully in the next 5 to 10 years, this will be the future. So I think I'll stop here and would be happy to take questions. Thank you very much.
Thank you, Dr. Rupsuchi. Excellent, elaborative, extensive performance from an erudite speaker. And you left us with a very high octave note, like your piano playing. in the older days. So we'll come back to you, but before that, I think it's my pleasant duty to introduce today's panelist. Can I have the first slide? Yeah, I'll start with Dr. Rajesh Upadhyay, our gastroenterologist in today's panel, the Senior Director, Head of the Department, Gastroenterology and Hepatology in Max Super Specialty Hospital, Delhi. He is also the Dean of Indian College of Physicians and President of Association of Physicians of India 2015-16. He was associated with very successful national meeting of API few years back. More than 100 academic papers and various publications in various journals and book chapters also. Was also the editor of Medicine, which is very important for all the postgraduates appearing in post-graduation final examination of MD Medicine, and Hepatology, API Textbook of Medicine, and many others. Won the awards like prestigious B. Sira National Award and B. Parameshwara Lifetime Achievement Awards, Indian Medical Association National Award of Distinguished Medical Man for the contribution of highest order in the field of medicine. So he's also in the governing body of the All India Institute of Medical Science Partners. So it's my pleasure to welcome you. But I will go on with the introduction of our next panelist. Next slide, please. Dr. Rakesh Kumar Sahai, a friend of mine for last 2 decades or so. He's a professor and head of Department of Endocrinology, Osmania Medical College and Hospital. He's a consultant endocrinologist in Sahai's Endocrine and Diabetes Center. He's also the president-elect of Endocrine Society of India. Currently, he's a current president of Endocrine Society of India for all practical purposes. Vice President, South Asian Federation of Endocrine Societies, Founder Secretary of South Asian Federation of Endocrine Societies. He has been the Associate Editor of Indian Journal of Endocrinology and Metabolism and Section Editor of Tropical Endocrinology and Endotex. He has got 150 publications in various national and international journals, and he has won various awards and fellowships. So it's my pleasant duty to welcome my friend, Professor Rakesh Kumar Sahai, to this panel. Next slide, please. It's again my pleasure to introduce to you Dr. Mangesh Itivaskar. He's an internist and MD Medicine, FSCP, and various other fellowship he has won, already awarded, and he's a consultant physician diabetologist from Shilpa Medical Research Center in Mumbai, gold medalist both throughout his career, MD and MBBS. He's an honorary general secretary of National Association of Physicians of India, so it's a big honor to have you here, sir. He's also in the editorial board of very prestigious Journal of Association of Physicians of India and Medicine Update. He's in a governing body of wisdom representative of ACP, a guest editor, Insulite Journal, World Journal of Anemia. Has delivered more than 1,000 lectures at various international and national forums, and he has written multiple chapters. He has published in innumerable articles in various prestigious journals. So it's my pleasant duty to welcome you here, Dr. Mangesh Itivaskar. And finally, it's my pleasure to introduce to you Professor Subhankar Chaudhary. He is like elder brother to me. He's a professor and head of Department of Endocrinology, IPG, MER, and SSKM Hospital, Calcutta, a member of and subject expert committee of CDSCO, Government of India, founder patron of South Asian Federation of Endocrine Societies, immediate past editor-in-chief of Indian Journal of Endocrinology and Metabolism, immediate past president, Endocrine Society of Bengal, more than 200 publications in various peer-reviewed journals. He is currently working on gut microbiome, which is somewhat related to today's topic, and also in gestational diabetes mellitus and pathogens of Graves' obesity. From my side, I would add one more line. He's one of the persons who was instrumental in changing the landscape of endocrinology in the eastern part of India, more particularly in the city of Calcutta. So welcome you, sir. It's a pleasure to have you here. So today with these 4 panels, I'll start with Dr. Rakesh Sahai. Rakesh, are you there? Yeah. So my question is, how often you encounter diabetes patient reporting with GI symptoms? I'm not talking about exocrine pancreatic insufficiency, but as a whole, GI symptoms. You have seen huge numbers of patients over these years. And is there any age or gender preponderance of, can you actually describe a typical phenotype which can lead to a diagnosis of exocrine deficiency from the knowledge we have gathered from Dr. Rupjyoti's talk today? So Rakesh, please.
Thank you, Manas, for the kind words of introduction. And before I go on to answer the question, I would like to thank the organizers today for inviting me to be here on this prestigious panel, and also to Dr. Rupjyoti Talukdar for a very excellent presentation which he made. And actually he brought in very new insights into this whole problem. And I think I should congratulate him for the excellent overview he has given on this, and he has brought in very, very new insights into this. So coming back to the question which you said, what I would like to say is that we do see maybe about 10 to 20% of our patients having this problem of gastrointestinal disturbances, and many of them, if we look back, I mean, we have not really actually evaluated them for exocrine insufficiency, because this was not something which we are doing it routinely. So we have not been evaluating them for exocrine insufficiency. But I would roughly say about 10 to 20% of patients, and more so with longer duration of diabetes. And if you look at sex, probably females have a little higher prevalence of this problem. This is just what I'm saying from clinical experience. I mean, I don't have hard figures to quote this, but this is what I've been looking back and thinking about this from the perspective of today's talk that we just heard from Dr. Rupjyoti. I think these are the points that I would like to highlight. If you would allow me, I would just like to ask Dr. Rupjyoti a question. Because he has told us about the different tests that can be done, and practically probably we have only the elastase, fecal elastase. But in situations, in centers where different tests are available, is it the same, the prevalence the same with the different tests, or does it vary with different tests? If you are going to two of these tests to compare that, or different tests to be if you do it, would you find the prevalence the same in would all of them be positive on different tests, or there would be differences in the prevalence as per that?
Right. So actually, if we talk about the fecal elastase, my worry is it has a tendency to overdiagnose exocrine insufficiency. We have seen that even for normal persons. So in our clinical trials and other studies, in many healthy controls also, we used to do fecal elastase under research protocol. So many of them actually turned up showing exocrine insufficiency, like less than 200, but they're not having any symptoms. So fecal elastase, even though it is widely available in India now, we have to be a little careful because it has a tendency to overdiagnose. So that's number one. Otherwise, we don't have any objective tests in India as of now. So we have to rely on the other surrogate markers. Again, those surrogate markers may not necessarily give us the actual incidence or the prevalence. They are just, they can give an idea that, okay, this patient might be having exocrine insufficiency. And if we talk about the direct tests, they are the best actually. The direct tests where we put endoscopic tube and drain out the bicarbonate secretion or the CCK. But again, they are not available in India. Even at AIG, we are not, it's only at the Mayo Clinic. So those are better tests. They will give you a more accurate picture.
While you are presenting your case, you just mentioned about the size of the pancreas. Looking back, I recollect many patients now seeing reports of, the thinned out pancreas, even on ultrasonography.
Right.
And we never give that importance because, we are not aware of what is the consequence, what is the significance of that. So thinking back now, I can recollect many instances where I've seen reports where the reports have thinned out pancreas, even on ultrasonography. And can you
that
just
is an important that is a very important function, important finding. So that could give you a clue that the patient's pancreas is getting atrophic and exocrine function is getting lesser and lesser. So if we go by the literature, overt pancreatic exocrine insufficiency happens when the pancreas parenchyma is 80% damaged. That's when the patient will have steatorrhea and over malnutrition. But then in the earlier part also, there will be progressive loss of the pancreatic function. And in case of diabetes, especially when the patient requires insulin, there is less insulin from the islets. Even there could be functional loss. There may not be gross atrophy, but there could be functional loss of the Axiner function. So in those cases, if the patient has an atrophy of pancreas, smaller size on ultrasound, CT, whatever you do, and other signs that could suggest malnutrition or exocrine insufficiency, bloating, weight loss, those should be considered as exocrine insufficiency patients. And you can try a short trial of ERT, exocrine, replacement therapy. And if the patient is improving, you'll get the results in 4 weeks. Because once you give the enzyme, they'll start digesting, they'll immediately respond. So that would be the diagnosis that these patients actually had pancreatic exocrine insufficiency. And then you can continue the PERT.
Yeah, Rakesh, in this context, I want to ask both of you, I talked about the phenotype, see, 20 to 30% of diabetics, it says type 2 diabetics are having exocrine insufficiency. That's a big number. Looking at the number of diabetics we have in our country. Now, to detect or at least do something to these people having a clinical condition, do we need to develop some kind of a scoring system or some kind of a phenotypic description so that our clinicians find it pretty easy to pick them up and start treatment? Or is it too early to think about such a clinical, scoring system or something like that? Because for various diseases, we have some clinical scoring system.
I think it is going to be very important because we don't have very good diagnostic tests. When in the absence of a good diagnostic test, the need for a scoring system comes in, the clinical scoring system where we're looking at these points. And I was also wanting to know whether we can have certain dimensions which could predict that, below these dimensions of the pancreas on CT or on a particular imaging modality, could we say that this could predict with so much sensitivity the presence of pancreatic insufficiency?
So I can.
Can I come in?
Please,
so this is a very important point that you have raised. We definitely need a scoring system. I strongly agree on that. Regarding the size cutoff, from chronic pancreatitis literature and experience in the practice, so what we see, there is no good correlation between the morphology and the function of the pancreas. So even a CT scan sometimes shows a very atrophic pancreas, still they're not malnourished. And sometimes even a plump pancreas, the patients are so they don't correlate. And otherwise also, these are all two-dimensional imaging. If we really want to have a 3D volumetry on CT or MR, so that is not available at all places. That will need expertise. And probably at this point in this country, we cannot make that a routine practice to report a CT volumetry. So that is a hindrance to using CT size as a cutoff. But I think based on clinical parameter, gross pancreatic atrophy, we can work on developing a scoring system and then put to trial. All of you are so accomplished people. You have so many of these. We put to trial and then we can validate.
So this is a food for thought, and we will come back to that at the end of the discussion because we have got Dr. Mangesh and Dr. Subhankar sir here, and Dr. Rajesh also is here. So my next question is to Dr. Subhankar sir. It's a bit controversial, but then it's very important from a astute clinician like I want to know, because we have now a lot of diabetic patients, and obviously the prevalence of this disorder is pretty high. And would you like to advise our clinician friends, primary physicians, because they will be handling most of the diabetic cases, and in turn they will be handling most of the exocrine pancreatic deficiency insufficiency cases also. Would you like to ask them to go for a clinical trial of replacement, exocrine pancreatic replacement therapy? That if you say so, if we say so, if any consensus says so, then it will be huge numbers. The prescriptions are going to be going to come in huge numbers. So what is your opinion? What is your advice to the primary physician or family physicians who are handling diabetic cases on day in and day out basis?
I think what we learned this evening from Dr. Rupjyoti's excellent discourse is you may not have overt steatorrhea in order to have pancreatic exocrine as a manifestation of pancreatic exocrine insufficiency. And in fact, it is my experience when we see the patients with so-called FCPD, and we do see many of them. You also see probably Manoj.
Yes, yes.
Most of them do not have frank steatorrhea.
Yeah.
That may partly, and I explain it, I do not know how Rupjyoti would explain, partly is because their overall fat intake is quite small. So therefore it doesn't manifest as steatorrhea. So that may be one reason. That if you wait for that, then of course we'll miss many. So overall, I think there are some symptom, some sort of scoring as we were discussing, if we could agree upon. And based on that only, you have to select and then try and use medications. The other important issues, of course, are, and Dr. Rupjyoti, I do remember another study. I mean, you referred to one study on use of pancreatic enzyme and looking at HbA1c value. There was a very old study from our country itself, from Professor Mohan, B. Mohan, which did suggest that pancreatic exocrine enzyme replacement therapy did lead to improvement in HbA1c, but of course that wasn't a very well conducted study. So if we do have more solid evidence that this also helps in improving glucose control, then there may be another area where this could be tried. But of course, that's becomes quite a costly sort of venture in terms of improving glucose control. Will be much more costly than using insulin and whatever the other agents, established anti-diabetic agents. The other more intriguing but extremely important to consider, but consider as part of studies, is the suggestion that mild, moderate insufficiency could give rise to long-term health concerns, not directly GI, not directly steatorrhea, diarrhea, etc. It could affect bone health, for example. It could affect cardiac, cardiovascular, through alteration of lipoproteins. If those are really borne out, then there may be a even stronger case for using pancreatic enzyme replacement in more and more patients with diabetes. Maybe I didn't answer your question, Manoj.
I know
exactly.
I think you cannot answer it because I think we need more evidence, and we should be on a stronger ground to say that yes, it is required for a diabetic patient, because that's going to be a very big statement. I mean, you cannot make a big statement without good quality evidence. But assuming that many of our patients would require exocrine pancreatic replacement, I will ask my question to our next panelist, Dr. Mangesh. What is your experience in your practice? You see a lot of diabetic patients in this kind of prescriptions, and what is the approach? Like, you start low, go slow, or you go for a short course of trial, or you do it a long course for prophylaxis, or you give a very high dose to start with, like what Dr. Rupjyoti has said, like maybe 50,000, maybe 25. I prescribe low dose only because I have seen gastroenterologists prescribing high dose, but my patients won't be buying probably if I give a high dose because of a cost issue also. Would you like to start with a high dose and then gradually taper it off, looking at the improvement of symptoms? You take a chance, like, okay, with this much, if the patient is doing well, maybe I'll keep him at this. Okay, so what will be your approach?
Thank you, Dr. Manus, and thank you. Before I answer your question, compliments to Dr. Talukdar. One of the most amazing sessions that I must have attended of late. And honestly speaking, your passion for this topic was so evident on, the way you were presenting, and the amount of the work that you have put in for this probably whole concept development is worth not only a salute but appreciation, sir. And thank you, Hetero team entirely, Shweta and Pooja and Nehru and everybody. Thank you very much, Mohammed. We appreciate that. Now, coming to your question, Manash, it still is a gray area, even though we had a lot of challenges in even diagnosing, as Shubhankar sir has already pointed out. Now, when we really think about diabetic patients developing this exocrine pancreatic insufficiency, it's very difficult to differentiate even whether are you really dealing with just an exocrine pancreatic insufficiency, or are you also simultaneously dealing with an autonomic dysfunction? like the autonomic gastropathies or gastroenteropathies, which can be also one of the commonest happenings. So previously we never had guidelines, so everybody practiced in their own style. Some started with very high dose, as probably Dr. Talukdar would agree, that start on with high and especially insist on lipase, which is the most important aspect of the whole therapy, that you cannot replace lipase by anything else. So you need to consider lipase. But as Dr. Shubhankar sir has really beautifully pointed out, that the first reflex action of any physician who probably thinks that we are dealing with an exocrine pancreatic insufficiency and the patient is presenting with possible steatorrhea, the first advice on the prescription paper is stop diet, stop fat intake, or stop. And that is one of the reasons and limiting factors, as beautifully Dr. Talukdar has brought out this point. Very, very, I would say, mesmerizing point that you have got, and such a simple common sense which probably we all missed throughout. So I'll still stick to the guidelines which are coming up now, and especially the Pancreatic Society of British and Ireland has recently published these guidelines.
Yes,
it has been beautifully published in this month only, and they have really insisted on assessing the patients, individualizing the therapy. But I still will go probably start with the right dose, calculate per kg dose, start on with that, and then depending on the symptomatic benefits, you need to go ahead and manage these patients. Keep a watch on not only the symptomatic improvement but overall improvement. And as far as your scoring system is concerned, I just was wondering how we are going to really approach, because it is such a I would say clinical diagnosis. It's a diagnosis of suspicion. It's a diagnosis where you do not have absolutely clear pointers. So to have a scoring system, you need pointers. So that is the biggest challenge. And as Dr. Talukdar has really nicely elaborated, that volume assessments or volume evaluations by any radiological investigation are probably not the only ways of judging the entire exocrine pancreatic insufficiency.
Thank you so much. Thank you so much, sir. I now come to Dr. Rajesh Upadhyay, sir. So I will look for your comments or other gastroenterologist perspective on the two issues which were discussed by Dr. Shubhankar sir and Dr. Mangesh. Number one, at what frequency are clinicians should be advised to prescribe these exocrine supplements, and what would be your perspective like? As Dr. Mangesh said, you would start with a adequate dose, and how long, and what is the other side of the coin? Like, what are the difficulties you face by prescribing this exocrine supplements? Is there any side effects which you want to tell our audience today? Because everything cannot be good or may not be good, but we have to be aware of the the other side, the darker side also, if there is any.
Thank you, Manas. Now, let me start first by congratulating Rup Jyoti. I think he has opened up a new business completely, new insights. He talked about the pathogenesis, which is not that well known. He's provided some very practical ways of managing. And really what comes out of the whole thing, that we need a whole load of research and a lot of collaboration between the gastroenterologists and the physicians.
True.
And endocrinologists.
Yeah.
Now, as far as the practical issues are concerned, being a gastroenterologist, clearly we are only referred patients who have problem. The commonest referrals for diabetes these days is for fatty liver disease, NASH, cirrhosis, etc. But we get a sizable proportion of patients who have chronic diarrhea, who have gas, bloating, which is not responding to the standard treatment, and some patients who are losing weight and suspicion of gastric GI malignancies, etc. And I think in all these clinical situations, one has to suspect. But question of when, I think a very important point was raised by Mangesh, that you may not, in a diabetic, when we see a patient with diarrhea, for example, it could be drug related, it could be autonomic neuropathy, it could be small intestinal bacterial overgrowth, it could even be microscopic colitis, and pancreatic certainly has to be thought. And lastly, it could be a combination of these. So one has to be very clear And since there is a large percentage of patients who present with diarrhea and some weight loss, etc., who have small intestinal bacterial overgrowth, the first and the simplest way is to give them a course of rifaximin and see if they go. However, if there is significant symptoms, then that is certainly an area where we do investigations. Now, should we investigate all the diabetics, the 75 million or so diabetics who are there in India? Certainly not. And I think we'll have to stick to a very small proportion for the sake of practicality as well, those who have got symptoms. And the predominant symptoms I think we have to look for is there evidence of diarrhea, malabsorption symptoms, weight loss symptoms, or there are a subgroup of symptoms with gas and bloating. Now, lots of them are diagnosed as diabetic gastropathy, and we don't do too many tests for diabetic gastropathy as well. So a number of these may be actually having pancreatic insufficiency. So from this talk, what I think the message should go is that we certainly must have very low threshold for investigating them. And that investigations in presence of any of these symptoms, fecal elastase test, I would say, is reasonably well available very widely. Yeah. And it is not that costly, I would say. Therefore, doing a fecal elastase test is certainly going to be, at least provide some practical. Now, what do we see in practice? And I entirely agree with Rup Jyoti that there can be many false positives. But what we do in clinical practice, if you have a clinical features which are suggestive, and if you have less than 100, then I think that means that we take that as a diagnostic criteria and start them on the PERT. For other patients, if they are not that symptomatic, you have, the fecal elastase, which is a little lower, maybe 150, then I think that is a difficult or a gray zone where we have to decide. So I think overall, patients who, from clinical standpoint, patients who are symptomatic should be investigated and provided with the PERT as and when required. However, we can only, and I think this is a very good moment to think of a collaborative research work between the endocrinologist and the gastroenterologist to actually widen the horizon, to try and bring up guidelines in this area. And I think Rup Jyoti has opened a very important area. All these years, I've been talking about diabetic hepatopathy, because that the diabetes and liver, which is the chicken, which is the egg, etc., has been of a load of interest. Now I think we should come up with a diabetic pancreatopathy, because you see, it is not only all these years we knew that pancreas causes diabetes, but it's the other way around as well. And the mechanisms which have been elaborated and shown by Dr. Rup Jyoti should provide some incentive to look in that area. So I think overall clinical standpoint, I've made very clear. Now, the other question was how much? Once we decide to treat somebody, we certainly start at 25,000, which is the standard dose available. 40,000 is available as well, but we normally do not for reasons of practicality, and I think cost issues have also been mentioned. And we then gradually come down over the next few weeks or months, but it has to be gradual. And I think for a large number of patients, we've been able to maintain on 20, and some patients even on 10,000. So that is the way to go. Now, is it effective? The answer is very simple. Yes, it is very effective. But is it safe? And I think your question was the safety aspects of it. What side effects do we see? Well, normally I don't see too many side effects from this. However, some patients develop constipation or maybe a little abdominal pain sometimes. Other have been described, but really in my practice, I see very little of side effects with PERT treatment. So I would consider the treatment as very safe and go ahead whenever it is indicated. And go start from a dose of at least 25,000. Does that answer your question?
Yeah. You have clearly stated everything, and it's very good perspective from an experienced gastroenterologist like you. So my next question to both Dr. Subhankar sir and Dr. Mangesh, like gut microbiota, well, it has been discussed so much recently in endocrinology, and there are schools of thought saying that there's a vast majority of diabetic patients are basically having the disease because of change in gut microbiota. Some are obsessively campaigning in favor of that as one of the main pathophysiological mechanisms. And in fact, there are many pharmaceutical companies which are thinking about developing drugs in that area. So, Dr. Subhankar sir, it's very exciting. It's a way to go forward or think about it. And you have done some original work recently on this. And so what is your take? And then I'll come to Dr. Mangesh.
I think it's exciting, no doubt about that. And however, a lot more needs to be done. In the past, we believed that A, B, C, D bacteria are bad, E, F, G, H are good. Now, I feel my understanding is more than individual bacteria or their genus or species. It is more the diversity of the microbiota, which is important. The more diverse it is in general, the better. And in fact, if you look at the studies that have been reported, there have been contradictory evidence in favor of particular mycobacteria. Some have suggested that these are associated with type 2 diabetes. And then the ones associated with obesity are quite often some other group of bacteria. So this is still, I feel still we do not have a simplistic answer. Whether we will come to it at the end of maybe a very intense work being done across the globe over the last 10 years or so, I have my doubts, but they have been excellent propositions, mechanistic studies to suggest how and why this could happen. But till date, I do not have a clear idea. That's unfortunately my take.
Yeah, Dr. Mangesh, how do you look at it?
Yeah, I completely agree to what Dr. Subhankar sir has. It's very exciting. It probably has provided the ray of hope, especially in these struggling times when we are trying to, actually look at maybe possibly reversing diabetes or preventing diabetes also. No? So if at all, probably we are all exploring all these, horizons. And of course, we have definitely have some, past evidence really from our old sciences, old thought processes. There are various ways where, we were thought about exposing to the, not only the human microbiota, but otherwise also, if you really remember and go back to those golden age around a century ago, probably go back to the villages and they use a lot of cow dungs and all that to, spread or, and, with all those possible exposures to, only in a view as Shubhankar sir has said that, more diverse microbiota you have, probably better healthy microbiota, you definitely get benefited. So possibly, yes, a new way probably requires more, more research, more understanding of it. In therapeutic intervention or interventional use is still, I feel that it's still a distant area where we need to first clearly establish the absolute clear correlation between the, two problems. And once we do that, probably that will again open up one more armamentarium for the management.
Dr. Rupjyoti?
Yeah.
So what is the update? Like, what is latest in the scene? Like, what is the future?
Yeah. So one thing which I agree 100% with both Dr. Mangesh and Shubhankar sir. Exciting, but we are still in a gray zone. One problem is the microbiota is such a dynamic thing. So in the same group of cohort, you will see lots of variability. Beta diversity will be very high, and so that's why it's very difficult to interpret. And again, Shubhankar sir has said there is contradiction in similar kind of study. In obesity, there is a different set of bacteria. In diabetes, there is a different set of bacteria. So I think first of all, what would be important to do is set a standard of doing this experiments or doing this work, how to isolate the microbiota, what would be the inclusion and exclusion criteria. So those should be uniform in all studies. So I think that should be the first, so that the data that comes out is homogeneous and we can really extrapolate it to the disease. So that is one aspect. The second aspect, again, it's not the bacteria by itself which does all the things. It's the metabolite, the metabolome. And now metabolomic studies are coming up. Again, it's a new area. So to understand the interaction between the microbial diversity changes and the metabolomic alteration, that would be even more important, because ultimately what would happen, the glycemic status or any phenotypic event is mediated by the metabolites, not the bacteria by itself. So I think that would be the next step. Now, once we understand the microbiome, then see the microbial metabolome interaction and how it interacts with the body physiology. So I think we are very early, even though good quality studies are coming in journals like Nature, Science, but I think still we are far away from reality, and I think we should have more homogeneous way of doing the things. So therapy.
Okay, can I ask a question to Rupjyoti?
Yes, sir.
So we often have taken recourse to fecal microbiota.
Yeah.
And it's suggested that may not be properly representative of what's happening higher up in the intestinal tract. And I mean, we as general physicians, physicians, endocrinologists, not gastroenterologists, we hardly can ever do, and large scale studies can hardly ever go on doing endoscopies, taking samples from way down the intestine. So are we getting at the right sort of information if we are just looking at fecal microbiota?
True. So I think it depends on what context you are looking at the microbiota. If you're looking at ulcerative colitis or large gut diseases, then it is fine. But if you're looking at liver diseases, for example, NASH, I think it's the portal system that will take the metabolites from the small intestine. So in that context, I think the jejunal microbiota or proximal ileal microbiota would be more meaningful. But again, to get microbiota from that area is a challenge. I mean, you have to either take mucosal biopsies or jejunal aspirates, which may not be feasible at all places. So I think, yeah, you are right. It depends on what disease we look at. That's what I believe.
Dr. Rupjyoti? Yes, sir. Please.
One little thing which came to my mind. In clinical practice, Rupjyoti,
yes, sir.
We, instead of seeing the atrophic type of pancreas, I see more often fatty pancreas.
Yeah.
Okay? And normally we look at it in association with the fatty liver and so on and so on.
Right.
However, is there any study to look at whether the pancreatic exocrine insufficiency is more common in patients with fatty pancreas? Because that is where the fat will start the whole cascade of inflammation and fibrosis, etc., in the same way as they do inside the liver.
Right. So that's a very important and practical question, I would say. So again, just like NASH, which became a very hot topic many years back, now the non-alcoholic fatty pancreas or the fatty pancreas is coming up as a topic of interest of several workers globally. There is no definite, as of now, no definite indication that fatty pancreas could lead to acute or chronic pancreatitis or exocrine insufficiency. It has to be studied. While saying so, there are a few studies which have shown very elegant clinical and basic science studies from a person called Vijay Singh. And now he's in Mayo, Florida. So what he and his group had done was they clearly showed that if the fat in the pancreas is higher in proportion, they have more severe acute pancreatitis. So the severity of acute pancreatitis is high if the intrapancreatic fat is more compared to a leaner patient. But still now we do not know the question you asked if exocrine insufficiency is more in those patients. So that is again a virgin area that can be explored. And I mean, I think that's a very important point.
Yeah, Dr. Rupjyoti, I want to take you to the Axiner cell now. You have very interestingly, you have showed that there are insulin receptors, maybe the insulin acts on the Axiner cells, and their Axiner cell to some extent depends on presence of insulin for their action.
Right.
And now, how does insulin work there? Is it so that the usual insulin receptor?
Yeah.
Or, It's a paracrine function, or not endocrine. There's a paracrine function, just
Paracrine.
a
Yeah,
transfer of insulin to the acinar cell by diffusion,
Yeah,
just
it's
by concentration gradient.
right. So if you remember the anatomy morphology of the acinar cell, there is the apical surface from which all the enzymes go into the pancreatic ductules, and there will be a basolateral surface which is wider. It's a pyramidal cell. So the basolateral surface, there are several insulin receptors and also GLP-1 receptor in the recent Cell paper that I had shown. So when there is binding of insulin to the insulin receptor, there will be downstream signaling through different mechanism. I won't go into the details today now, but it will lead to gene expression of the pancreatic enzymes. So eventually this signal will go into the nucleus, into the pancreatic enzyme. Those are proteins, and they will have gene expression. So the
just a moment. There are two pathways, MAPK pathways and serine kinase pathways. Which one is active in that post receptor signaling?
So I think it's the MAP kinase pathway.
MAP kinase. So because that has to be, because otherwise in insulin resistance scenario, that won't work.
Yes.
Because MAP kinase still keeps on working in insulin resistance scenario. That's why a lot of activities are increased during insulin resistance, like for example, uric acid retention or many other metabolic syndrome phenotypes are because of high insulin levels, not exactly because of insulin resistance. So it's obviously has to be a MAP kinase. Right. Okay. But next question to you is like, do glucose have any impact on the acinar cell, like high glucose or glucotoxicity? Can it adversely impact directly? Impact?
I don't remember any study that have addressed that directly, like just the way glucotoxicity can happen with the beta cells.
Yes, that's what I'm saying.
So, but then my hunch is, from whatever other information I have, there could be some functional defect if there is high glucose. But again, I cannot say with conviction. I don't have the hard data, but there could be some functional defect with glucotoxicity, because that will lead to some inflammation, and that inflammation may lead to acinar dysfunction.
Isn't it? Sorry.
Sir.
Isn't it suggested that hyperglycemia could also activate the pancreatic stellate cells and thereby could contribute to fibrosis and things like that?
So indirectly, yes. So Manoj's question was if it has any action on the acinar cell. But pancreatic stellate cell, definitely. There are several studies which have shown that high glucose can activate the stellate cell. And once stellate cells are activated, they will lay down the fibrosis, and that can indirectly cause inflammatory injury to the acini.
Yeah. So I think we have exceeded the time by almost 20 minutes. So it is time to wind up. But then before that, I will ask a brief comment from each of you. Yeah, I'll start with Dr. Rajesh Upadhyay, sir.
No, instead of making a comment, I will make a suggestion or a request. And I think this is a very new area which has opened up today. It's a very historic meeting, I would say, that, although some people know, but widely this whole area is not known and people are not fully aware about this. So we have our annual conference, the APCon, in Jaipur in January. And on this forum, I would like to invite Dr. Rup Jyoti maybe to give a talk on the same subject. And at the same time, I will request Hetero Healthcare to sponsor his talk.
Going further to what Dr. Rajesh sir is saying, is that let us have some, I would say, as he has already indicated, let us have some joint collaborative work done on this, along with API, probably Endocrine Society and Gastrointestinal Society. Because along with Gastrointestinal Society, we did some work with Dr. Rajesh and all that, as far as fatty livers and even in an area of IBS also. So I believe that this has really excited every one of us. So the concept of this exocrine pancreatic insufficiency and approach and management, it's a Pandora's box. We definitely know about.
Agreed.
And we definitely have now opened it. So
I think so.
Let's jump into it.
Important.
I believe that let us jump into it and try and come out with at least some basic understanding. If you start taking baby steps now, probably we may have more structured approach at least, we'll make people to at least suspect,
Sure.
just try and, suspect it at least, keep a watch on it at least, so that, some kind of therapeutic definitive interventions, which over a long term might benefit. And as Shubhankar sir has beautifully pointed out, that maybe gut microbiota is per se such a dynamic and probably a huge correlation, not only just because of the alteration of the whole thing, but exocrine pancreatic insufficiency definitely will play a role as far as short chain fatty acid metabolism or branch chain amino acid metabolism of the entire gut flora, and adding to the whole thing. So
I think Dr. Mangesh here rightly pointed out, and you represent API, Dr. Padhay sir represents API, and Dr. Subhankar sir is very senior, among the senior think tank of Endocrine Society, and Rakesh is there, the current president. So we just need to get somebody from Indian Gastroenterology Society, and then we can actually start with some kind of consensus building,
because this group, panelists are some of the most powerful people in the country in the medical fraternity.
Panelists.
So this is the right time to come and join hands together and at least begin. Once we start, many things will come up. So we have to just take the baby steps.
Subhankar sir, your view.
Can I?
Sorry. Rajesh sir,
I being from both sides, which means the gastro as well as API. So we've done some excellent work together, and we brought out common joint guidelines also. So I think we can seriously think about this and involve our very dynamic secretary, Govind Makaria, as well, and try and draw out some plans for future, with Rup Jyoti being on the helm of affairs as well.
That suggestion to as suggestion to hetero also, that start working on this. I believe Pooja, Shweta, and Nehru, you are listening to this.
Dr. Nehru and Pooja, you can come in now. We are not discussing little bit of political part of the whole approach.
In fact, now COVID has made you all rich, so it is better that
whether something has made us rich or not, but definitely any scientific initiative that
this was just a lighter side. Don't take it otherwise.
Glad to take it up. That's absolutely fine, sir. It's on the lighter side. I can understand that. But we'll be glad to be a part of any scientific initiative that the panelists suggest, and definitely those. I mean, the entire discussion, if you look at it, I think it went off really well, and in terms of understanding the challenges currently that we have. So definitely, I'll while closing the session, I'll give my comments at the same time. If we can further continue the discussion, that if there are any questions that are there from the audiences that can
the audience questions were there. Sorry, so we didn't have the access to it. Pooja, you have the access to it?
Sir, I have shared on WhatsApp. You have taken, you have taken one question already, Axiner once.
So because we are running out of time, so may I request you to forward these questions to Dr. Rup Jyoti so that he can, or other panelists if you choose.
Two are already covered, and just one
I can email also.
And one has just come, sir. So I have just shared with Rup Jyoti sir also.
Okay.
So if you can please,
and otherwise, if need be, I can email the answers. And this is Amita Goswami, I think Amita from Assam. So duodenal mucosal resurfacing going to play a role in type 3 diabetes management. So duodenal mucosal resurfacing is a fancy area in the gastroenteroscopist's domain now. In India, lots of work is happening at AIG and other places. Rakesh is doing lots of work in our institute, Dr. Rakesh Kalpala. So it has been tried in type 2 diabetes, in obesity as an obesity procedure that has also shown to reduce or improve diabetes. In type 3C diabetes, so far, we have not yet started, but conceptually it should work, because once the duodenum receptor, mucosa is eroded or removed, so there will be lots of change in the receptors, incretin, other neurohormonal receptors, and that could have some implication. But one thing I have to tell here is type 3C diabetes is also associated with chronic pancreatic inflammation. So if the result is going to be at par with type 2 diabetes, I can't comment. at this point. We need to look at that. But for type 2 diabetes, it is coming up as a effective modality. Type 2 diabetes with obesity.
And in fact, Dr. Nageshwar Reddy also is doing a lot of work there in Hyderabad.
Yeah. So yes,
so amazing.
So he had actually initiated the bariatric surgery, and now Rakesh is heading that group.
So I think so. All good things must come to an end. I mean, but then legacy must remain. Good legacy must remain. So let's see how much Hitaro is going to, back up this initiative of having a consensus amongst various experts from various fields. With this, I'll, from my side, I thank all the panelists, and Rupjyoti have done an excellent job. You have excited lazy minds today, and a lot of food for thought. And now over to the organizers for final word of thanks.
Before you hand it over to, let us compliment Dr. Manas for such a wonderful moderation.
Thank you so much. Thank you so
really
much.
Very, I would say, dynamic moderation with full amount of involvement. It was amazing the way you have conducted the whole program.
Yes.
And it was pleasure being an honor.
It's a privilege. It's a privilege, really.
Thank you very much. Yes.
Thank you, sir. Thank you very much for the wonderful session. As the panelists have suggested, definitely we'll be working towards creating a core panel to work on building the consensus guidelines on this particular aspect. We need a lot of work needs to be done. We know it is very preliminary stages and we are in the early part of the entire initiative. I think I must say that you set the ball rolling with the kind of discussion that we had. And you had also informed the kind of steps that we should be taking in the right direction to ensure that there is a more awareness and more information that needs to be disseminated. Understand this particular disease and providing the right kind of treatment. And definitely there are challenges in terms of the diagnosis and also in the part of the treatment. So a lot of work that needs to be done, and I will give an open acceptance in terms of whatever the initiatives that you are taking, whether in terms of creating more awareness in the local physicians group that will be taking up, and also at the same time creating whatever the white paper or the consensus guidelines. So with that, I say that Hetero will always be a part of what are the initiatives that you are going to suggest. So with this, I would like to thank our speaker, Dr. Rupjyoti Talukdar. I think he has made the Saturday evening all the more special with his wonderful lecture and great insights into this particular disease management. And I also would like to thank our panelists, Dr. Rajesh Upadhyay, Dr. Mangesh Tivaskar, Dr. Shobhanka Chaudhary, and Dr. Rakesh Kumar Sahai. So it's been wonderful to have such a nice, wonderful panel discussion complementing the session delivered by Dr. Rupjyoti Talukdar. And I must thank our moderator, Dr. Manas Purva, for wonderful moderation. And I must also thank each one of you for accepting our invitation and giving your valuable time on this Saturday evening away from your family to deliver this wonderful lecture. So with this, we thank everybody, and I thank the participants as well. We have the participants coming all across India from all the zones, and I think we have made this session really very interactive and wonderful for the audiences. So with that, we'll close this session, and I thank everybody. Thank you.
Good night.
Thank you, sir. Good night.
Thank you. Good night. Take care.
Thank you, sir.
And we'll be in
Thank
touch.
you.
We have to be in touch. Yeah.
Yeah,
Sure.
Definitely, sir.
Yeah.
Thank you very much. Thanks a lot.
Thank you, sir.
Thank you, sir.
Thank you.
I heard a lot about Rupjyoti sir for the last several years, but I think today it's great to hear. And
I think we are still live.
Dinesh?
Dinesh ji, we can